So it is my pleasure to introduce our final speaker of the morning session, Dr. Habib Benzian. My name is Benjamin Chaffee. I'm a dentist and an epidemiologist at the UCSF Center to Address Disparities in Children's Oral Health. And it's been my privilege at UCSF to lead, along with Dr. John Greenspan, a set of elective courses for our dental students in global oral health. And one of the conversations with which we open each of those courses is trying to get a handle on exactly what is global oral health. How can we put words that really define that term? And there's really been nobody as influential in that particular conversation at the international level than our speaker today, Dr. Benzian. He's a former Associate Director of Development and Public Health for the World Dental Federation, and he's been sought out for his expertise and guidance as an advisor for the World Health Organization, for the United Nations Children's Fund, and by multiple governments and non-governmental organizations. Through his numerous scientific articles and commentaries, he's doggedly championed for greater recognition of the importance of oral health when setting the international public health agenda. And he's called upon all of us who are in the oral health arena to mobilize for sustainable, evidence-based actions. Paul Farmer, leader in global health, describes global health not as a discipline, but as a collection of interrelated problems. And the problems we face in oral health are vast. 600 million children with untreated cavities in the primary teeth, and powerful economic forces that make for many the least healthy food choices those that are most accessible and most appealing. But in the interconnectedness of these challenges, there are opportunities. In his role as Fit for School International Director and as advisor to the Philippine National Health Program, Dr. Benzian has exemplified multifaceted, transdisciplinary global health action. He's championed not high-tech innovations, but rather efforts that are affordable, effective, and scalable. While some may see a certain lack of sexiness in toothbrushing and hand washing, there's no question that in Dr. Benzian's work, there's substantial creativity, resolution, and vision for a healthier future. Dr. Benzian.
Thank you. Good afternoon, no, good morning still. No, good afternoon already. Thank you, Ben, for this nice introduction. That leaves very little for me to say. I will actually repeat a lot from what has been said already this morning. We heard a set of highly inspiring and guiding presentations, and I think it doesn't hurt to repeat some of the things, because good stuff is worth repeating, and sometimes it's good to hear the same things from another person through another lens, and that's what I'm trying to do today. I will step back a little bit from the details of program implementation for a while, and I will take us back to the bigger picture of things. That was the task that I was given from the organizers, to speak a bit about the global dimension of the problems that we are here for. No need to introduce anything further. Ben has done that so nicely. So I will talk about the global challenges to oral health and nutrition. I will also expand a bit on the global opportunities for change, for lasting, sustainable change. Then we will go on an excursion to the Philippines, or to Southeast Asia, more precisely. I will explain to you a little bit about work that I've been involved for the last 5 years, the Fit for School program, Fit for School approach. And then I will try to come up with a few practical recommendations for all of us who work on a daily basis in this area, in this interface between nutrition and oral health. And of course, like all my preceding presenters, I would like to thank the organizers for bringing all of us here together, because this is a really unique opportunity, and I truly appreciate their effort to make this happen. Our world is complicated, it is very complex, and it keeps changing. I think that is a theme that came up in previous presentations already, but it's really worth remembering. Nothing is as simple as sugar equates obesity or sugar equates caries. It's not that simple. yes, one can make things simple, and it's sometimes important to make things simple in order to explain them properly to people who have no detailed knowledge, who are not experts. But it's also worth to keep in mind the complexities, to go into the details, to look into ramifications, and that is what academic research is about very often. So we need to bridge the gaps between this academic detailed focus of research and the real-life practicalities. How can we turn research that is very detailed and very special into something tangible that guides my work tomorrow? And that is often not so easy, and it's something that I will come back to throughout my talk. In the next slide, you see the nutritionist among you may know this. It's the Obesity Map developed by a research group at the University of Oxford. It shows the complexity of the problem of obesity. All of the different factors that play a role in the development of obesity are kind of listed there with their interrelations. That is mind-boggling. It is like, oh, what can I do? This is frightening. It's scary. And I can tell you the picture for care is not easier. If you wanted to do a map like this for care, it is as complex as that. But of course, we need to simplify. We need to scale down the complexity of the problem into something that is actionable. This is not actionable. Each and every one of you is maybe working in one of the bubbles which centers certain topic areas. But to bring the different groups together is a nightmare. It just doesn't work. It's not real life. So we have to go back to some of the basics. And as sound public health people, I think it never hurts to go back to the basics. And one of the guiding principles, the guiding frameworks for all our work is the Ottawa Charter for Health Promotion, which reminds us that health is created by people within the settings of their everyday life, where they learn, work, play, and love. So while we think it is about behavior, it's about factors, it's about bugs, it's about anything else, it's all of that together that makes people healthy or unhealthy. So what are those things? Of course, where you live makes a difference. Whether you live in a crowded place like this in China or whether you live in a well-off Berkeley neighborhood makes a difference. It makes a difference whether you have electricity or not. That's a level of comfort, of sophistication, of lifestyle that you can afford or cannot afford. One quarter of the world's population still lives without electricity. Imagine your life without electricity. It's very difficult. More than 2.5 billion people have no toilet. That means no toilet at home, but also there's no toilet at school or at the workplace. So how do you deal with your most urgent physical problems? You go behind the bush. Where children play matters. Is their environment safe? Is it clean? Does it provide enough stimulus for their development at whatever age group they are? Traffic is a major determinant of health. Traffic kills people every day, and particularly children, and in this example here in the picture, on their way to school. Of course, where children go to school and to preschool makes a great difference. And whether they go to school or preschool at all makes a difference to their development. Fortunately, the world has made big progress in schooling rates and is on its way to improve preschooling rates as well. But they still lag behind the schooling rates. But with big investments, catalyzed by the Millennium Development Goals, there is big progress in schooling rates. However, schools are not the healthy places that we would like them to be. 2/3 of schools worldwide have no access to water and don't have a toilet. Many of you may have seen schools in rural areas, and you will see there is maybe a toilet, but it's locked. It's locked for use of the teachers, or it's dysfunctional, or it hasn't been cleaned for I don't know how long. Of course, you don't want to use that. It's disgusting. It's unhealthy. It's filthy. So all of these examples are just reminders of the determinants of health. The determinants of health we should never forget. There's a range of factors which go well beyond our remit as health professionals. Those are things that are where we have never been taught to be active in. As health professionals, we have learned to deal with diseases. We have learned a little bit to promote health, but we have not learned on how to work, how to influence a work environment, or how to improve sanitation, or how to get involved with policy, agenda setting, and advocacy. So the determinants of health have regained attention, and rightly so, through prominent work organized by the WHO and others. Something that we need to keep in mind, the determinants are important. They determine how healthy or how sick you are. They determine the gradients along the socioeconomic status in terms of disease burden. Those of you who are from the dental arena among you may be familiar with this. It is an image from Aubrey Shaham, professor for dental public health in the University College in London. I go back to this quite frequently because it illustrates very nicely one of our main challenges. In the middle, you see the river of disease. People who are floating in the river, they are sick. They have fallen into the river because they got sick from manufacturers of illness, processed food. We heard a lot about that, about sugar-sweetened beverages, alcohol, tobacco, etc., etc. All those risk factors that we have mentioned this morning, they are up there. They make people sick. They fall into the river. They are ill. They need help. They cry for help. And what are we doing? We are throwing maybe some life-saving rings or give them some swim vest to help them swim better in the river of disease. If we live in a country with a national health system, we have doctors and nurses and physicians who help people dragging out of the river of disease. We give them medications. We put them in hospital. We give them care. We try to make them healthy again. But still, there are so many people floating down that river. It's impossible for the few people working the National Health Service or in healthcare to drag them all out of the river. So then the idea came, okay, so if they are sick, we have to learn them, we have to teach them how to swim so they can sustain themselves better in that environment which is making them sick. So this is where health education comes in. We empower people to stay healthy in an environment that is unhealthy. But for us as public health professionals, we have to make our decisions. At what point of this process do we want to intervene? Or where is our intervention the most effective? Is it dragging people out of the river? Or would it help if we prevent people from falling into that river in the first place? And by that, draining that river and making less people floating down that river. Just some food for thought. We heard this morning a lot about health education, about educating people, about changing their behavior, about influencing their behavior. But particularly in the oral health arena, we know that the impact of oral health education is very limited. The evidence for health education is slim. The effects of health education are short-term. We know very little about the long-term behavior change. So interventions that focus only on health education, they miss out on other opportunities to do something, to make a lasting change. So focus on health education alone is not going to change anything. You have to do something about the settings, about the other determinants that I mentioned. Let's talk a little bit about the disease burden and the risk factors. Saskia has already mentioned a lot. And she also mentioned sugar consumption and many other of the key risk factors that relate to oral diseases and to the other chronic diseases. And I'm not going to go into the discussion whether caries is an infectious or a chronic disease. I think from a public health point of view, we have to be very clear and steadfast about it. Oral diseases are non-communicable chronic diseases. They may have a window of opportunity where some bugs are transferred through infectious channels from mother to child, from caregiver to child, but that has no practical implication for programming. Our diseases, or the oral diseases, and particularly caries, should be considered as chronic, non-communicable. If I'm a decision maker in a country, and as Saskia said, I have $25 to spend per head for my population per year, where am I going to start? It's a very, very tough choice. Of course, I know that the key killers of the populations that I'm in charge of are still the infectious diseases, diarrhea, respiratory tract infections. We have worm infections. More than 2 billion people worldwide are suffering from intestinal worms, which have a huge impact on growth, on development, on your daily life. It's a terrible problem, and it's one of the neglected problems worldwide. It's hardly talked about. But of course, in my country, I also see that there's a double burden, as we have heard. I have a large proportion of of children who are still underweight and malnourished, but I also have a growing population who are overweight and obese. So where am I going to start? What is my first choice of intervention? Very difficult questions, and they require a sound public health prioritization process, but they also require a society consensus about what are the issues that for our society, for our population, are the key problems that we need to tackle. Let me give you an example from the Philippines. In the Philippines, the National Health Survey from 2006 revealed 97% of 6-year-olds have caries. And it's not just one dark spot somewhere. This is a typical picture. The average is that children have about 3 teeth which have an open pulp. You can imagine that it's painful. It prevents a child from sleeping. It prevents a child from going to school. It's the most common reason to miss days in school in the Philippines. We did some research to substantiate the argument, and we found that 12-year-olds with dental infection have a higher risk of low body mass index. And we also saw that when preschool children got some treatment, when the teeth where the pulp was open and exposed were extracted, they were catching up on their lost body mass index within 6 to 9 months. And the main causal pathway seemed to be in that study lack of sleep, disturbance of sleep. So also, again, a very complex interplay between different factors that relate to body mass index and child growth. We came up with a model integrating tooth decay and untreated tooth decay into the bigger picture of child development, because that is something that is quite important for the child development community, the education community. They look at what are the factors that contribute to poor education performance, to poor child growth and development. And we believe that tooth decay, and in particular untreated tooth decay and the resulting infections, are a neglected element in this bigger picture. Saskia mentioned a number of statistics already about the prevalence of tooth decay measured either in one of the dental indices or in simple prevalence percentage numbers. It is very difficult to come up with a real good figure because our data is still very patchy. Not many countries have real representative recent data. If they have data, it is maybe from a capital, not really from a rural. You will find within one country huge disparities in disease burden. So giving a national average doesn't really say a lot about what the reality is like. Even here in Berkeley, you will find a good proportion of people with virtually no decay, but you will find a very small fraction of population with very high decay, with very severe decay, equally worse to the situation that we have seen here from the Philippines. Looking at it in terms of distribution between income countries, income groups. On the left hand, you have high-income countries, and on the right hand, you have the low-income countries. Those are the classifications that the World Bank uses. And this graph looks at how many teeth, what is the level of tooth decay in terms of the DMFT index, how many of the teeth are untreated, are missing or are filled. So you see that the highest disease burden is in the countries with upper middle income, and the lowest burden of disease is in low-income countries. And we have heard already a bit about the factors that are associated with this. So this distribution of populations between income groups is a quite interesting thing. When we look back at the picture 20 years ago, 1990, we had about 15% of the world's population living in our living conditions, high-income countries. And we had about 2/3 of the world population living in low or lower middle income countries. And that means living around $1 to $2 per day. Okay, that was 20 years ago. The picture has changed dramatically. In 2011, the most recent statistic that was available, we see that the proportion of people living in high-income countries is more or less stable. But then we see a huge increase, more than 2 times increase in the upper middle income country category, a dramatic increase in the lower middle income country category, and just 11% living in low income countries compared to the 57% 20 years ago. And when we think back of the graph before, that the highest burden of tooth decay is in the middle and upper income country group, you will see that with this increase, we have to expect much more disease, much higher disease burden. And this is exactly the facts underlining the transitions that we have heard about. It's not just about caries, it's about nutrition, but it's also about a range of other diseases and exposure to risk factors where we see this transition. This is a similar picture to the one that I showed you before, but it shows you in a more clearer way the proportions between how many teeth are untreated if they are diseased and how many teeth are treated. You would think that in the US, as a high-income country, we treat virtually all decay. It's not true. The picture here for 12-year-olds is that almost half of tooth decay remains untreated. And the more you go to the right, to the more low-income country groups, you will see that the proportion of untreated decay amounts to almost 100%. So worldwide, when we talk about populations living we saw that only 16% live in high-income countries. The majority of people live in the other income country groups, which says that the majority of tooth decay worldwide remains untreated. And people go with pain. They go with impacts on their daily life. They go with suffering. If you have toothache, and I'm sure that almost each and every one of you had toothache in their lifetime, you go to a dental clinic. You find a dentist. You have some kind of coverage, you have some kind of insurance to cover for your care. If you live in a middle income or a low income country, there is no such thing as a dentist readily available. For the majority of people, the quality of care is something around this, if it's not quacks on the street side, or there's no care. And what you do, you go get a painkiller, or you go to the market or the pharmacy and you may get an antibiotic. Oh, we know the nature of toothache. It goes and comes. It comes and goes. You may be fine for a couple of weeks or a couple of months, but the problem comes back, and it comes back worse with more complications. Karen has already said it in her nice diagram. We need to place more priority and emphasis on prevention and self-care, starting as early as possible, because it is impossible to treat away all the caries that is there. It is just impossible. Fluoride has been mentioned as one of the success stories in public health of the 20th century. A program for salt fluoridation in Jamaica, supported intensively by PAHO, was featured prominently in this publication from the Center for Global Development in 2005. And subsequently, there have been other publications highlighting this success. Fluoride toothpaste, fluoride salt, water fluoridation, those are public health interventions with proven success, where we have good cost-effectiveness studies. Those are our best buys when it comes to public health interventions. But the reality, for example, toothpaste, fluoride toothpaste, the WHO says that only 10 to 15% of the world's population really have access and use fluoride toothpaste on a daily basis. We don't even think about it because 90% of our toothpaste is fluoridated and it's readily available at every corner. But that's not the case for every part of the world. Also reiterating something that Saskia mentioned already this morning is the aspect of integration and alignment. We have a very sound conceptual basis to integrate and to align oral health into the mainstream of child and adult diseases and chronic diseases. The basis is the common risk factor approach, as we have seen it already. A relatively limited set of key risk factors contribute to a range of diseases, and most of them are of chronic nature. And that is the basis for fighting for recognition in this context of the UN High-Level Summit. Saskia mentioned that already. It was a landmark achievement for the health and development community to have NCDs recognized at the United Nations level. But it was also a landmark achievement for the oral health community to have oral diseases recognized. And it's just this one little word in Article 19 of the Declaration, where oral is placed between renal and eye, so right where we sit in the anatomy, eye, oral, renal, somewhere in the middle. And it seems like a smallish achievement, but I can tell you it was a very tight and uphill battle, very highly competitive environment. Of course, every disease group wanted to be part of that declaration, because with this declaration comes the alignment of public health agendas for the next decade, which means also funding streams will follow that. Priority is given to NCDs and to the diseases listed in that declaration. Funding will follow, and focus of national health systems will follow. So it keeps people in business as well. On the occasion of that summit, the side event was organized by the government of a couple of governments, Tanzania, Sweden, Australia. And on that occasion, Helen Clark, the chief of the United Nations Development Program, she said, oral diseases are an obstacle to development. This is a very bold statement. We don't hear this very often from high-level UN officials. And this is something we should keep in our memory and go back to when we advocate for better recognition. However, when we look at the reality right now, how is development assistance to low and middle income countries distributed? On the right hand, you see the actual disease burden, and the red part in the middle is the NCDs. And on the left, you see that only this tiny proportion of official development assistance is allocated to NCDs. So there's still a huge amount of work to be done, and a lot of advocacy, and a lot of practical public health planning. What are the things that we can do and that we can offer to governments as best buys, so that NCDs are appropriately recognized in the spending, in the funding mechanisms that global health is working with. So that is one of the opportunities for advocacy and for change. But there are also others, sad ones. Some of you may remember this one. Diamante Driver in 2007, a young boy who passed away in Washington, because of complications from untreated tooth decay. He developed a brain infection and he passed away. This case created a huge outcry, rightly so, in the public health and oral health community in the US and worldwide to a certain degree. And it resulted in major policy change in the US. A lot of legislation was developed, people advocating for better inclusion of oral diseases and oral care in insurance schemes. But there are many other opportunities on the global scale which we can use in our local and national work. Saskia mentioned repeatedly the WHO guideline on sugar intake. It is a very important document that has just been put out for consultation. It is interesting for the fact that for the first time, the very direct cause-effect relationship between sugar and caries levels has been used to advocate for a reduction in sugar intake, which will benefit other diseases. So oral diseases have been taken as an example to show how diabetes and other sugar nutrition-related diseases can be influenced. For those of you working in school health and preschool health, they will know about the Education for All initiative, which is a very important international movement aiming at increasing schooling rates and improving education of children worldwide. And the goal number one is related to early childhood care in terms of health. So this is a sound argumentation base to say we need to do more for child health, including oral health and nutrition, of course. The post-2015 MDG discussions are ongoing, and complicated and comprehensive consultation processes are ongoing. What it seems now is that child health, the NCDs, and of course the determinants of health will feature prominently on this new agenda. And we have unprecedented momentum for school and preschool health programs worldwide, particularly for school feeding. Here's a graph from the latest World Food Organization, World Food Program, showing that about 400 million children worldwide get something to eat in school every day. And that is a huge opportunity that we haven't really tapped into, haven't thought about. We had examples from the country experience where unhealthy food was banned from school premises. That is an important start, but there's much more that can be done in terms of nutrition. School health as an opportunity and preschool, we have about 1.2 billion school-aged children, 88% in low and middle-income countries. And schooling rates are generally high. They hover around 90% in each and every country. Many countries achieve much more. So schools are places, schools and preschools are places where you can reach children very easily and where you reach them in a very captive age. That is where they are open to learn things and skills that last for a lifetime. In a school, every child participates equally. So school health programs are promoting equity. And I will show you some examples on how this really works. The World Bank has recognized school health and preschool health as a key element in the development agenda globally and have published a series of important guidelines and documents. We also did a chapter on oral health in this book of the World Bank to show that oral health matters. School health bridged the gap between health and education sectors. And that is how you get the whole education sector to buy into a school health program, because a healthy kid is performing much better in school. And the school performance goes up if kids go to school regularly because they're less sick and they can better concentrate because they're not so ill. And in every country, you will find more teachers than health professionals. So teachers are a very important workforce. Generally speaking, for school health, there is very good evidence for hygiene interventions such as hand washing, toothbrushing. There's very good evidence for school-based nutrition, range of feeding programs, supplementation programs. Extremely good evidence for school-based deworming, because you get the drugs to the kids instead of sending them to a health center and then distributing deworming drugs to the kids. And physical activity also has a relatively good evidence base. There's a not so good evidence base for just education-based interventions. And something that happens in so many countries, school health programs consist of screening only. Teams of health professionals, of nurses, and whoever volunteers go to school and detect disease. And they give a referral slip to the child. You go to some health professional and get the treatment that you need. This rarely happens. There's evidence and many studies showing that this link between the screening and the treatment afterwards is broken. It just doesn't function. If you do not provide the right incentives, if you do not follow up, if the threshold to getting care is too high. Let me give you a very quick example from the work in the Philippines, where we try to address some of those issues, and we try to bring it together in a comprehensive program, which is now the National School Health Program, School and Preschool Health Program in the country. In 2009, it was awarded by PAHO, UNDP, and World Bank for innovation in global health. Innovation, why? It is an integrated school health and water sanitation hygiene program. So it's not just an oral health program, it's not just a hygiene program, it combines things. So it bridges the gap between sectors. It is focusing on skills-based education, which is what the World Bank recommends for health promotion in schools. It is not just telling to wash your hands, it is providing the child an opportunity to wash their hands practically. If the child knows, even if the child knows that it's supposed to wash hands after going to the toilet, but if there's no water in the school, how can you practice that knowledge that you are told by the teachers? So the knowledge and the practicality of it needs to go hand in hand. And there are no health professionals involved. It is run by teachers. Health professionals just do supervision and training. The program consists of daily hand washing, daily toothbrushing with fluoride toothpaste, and that is done as a group activity. 10 to 15 children go to a washing facility where they wash their hands first and then they brush their teeth together. The advantage of doing it together is it goes faster for the teacher. You can do 10 kids in about 5 to 7 minutes. The kids can organize it themselves. There's a leadership role involved. There's some organization involved. And it creates peer pressure. They observe each other. So you are not doing it correctly. You have to do it this way. So it creates kind of a social norm of behavior. And it is a practical way of doing things rather than a theoretical information transfer. I should do it this way. Like we saw in the picture, someone standing in front of the class showing with a big model, you should brush like this. If you have never had a toothbrush in your hand, as you just told from the kids you gave the toothbrushes, they will not be able to do it just by seeing it. They have to practice it every day. And it's complemented by annual deworming because the worm infestation is so high in the Philippines and in many other countries. It goes hand in hand with improvements in water and sanitation. Schools that don't have access to water get a water access. Schools that don't have a toilet get a toilet. And that is done in close collaboration with the communities around the school and the parent-teacher organizations and whoever else plays a role in the community. The program elements are standardized, are simplified to the maximum, and pre-packaged. The material cost for such a washing facility where 10 kids can wash and brush their teeth is just less than $40. The running costs of the program are around 50 cents per child per year. That is for soap, toothpaste, toothbrush, and the deworming drug. So it's very low cost, even in view of the $25 of average health expenditure. So really affordable. The program is supported by the German Development Corporation in a bilateral agreement. The German government invests in initial seed funding. $1 invested mobilizes more than $6 on the Philippine government side. So it's a sustained engagement of the government, which is important because we all talk about sustainability, but we don't know how to achieve it really. And it does not work if the government is not involved. I was wondering when I was listening to your presentations from the field, what happens if your NGO stops working or if the funding dries out? What happens to your activities? Will they go on? Will someone else carry on? Or what happens if you personally will no longer be involved in the program? Is there someone else in the NGO as enthusiastic and motivated as you are to carry on with the activities? It's food for thought. What I liked about the examples that we heard is that there was some level of research going on and monitoring and evaluation. That is an important element in everything that is done. And we should really invest more in this because this is important for our program planning, for knowing what works, for learning from the experience. In the Fit for School program, we have a rather comprehensive research program, and we have published a number of results. We have a longitudinal cohort study looking at the effects of the program. Already after 1 year, we saw a reduction of days of absence by about one third. The number of children with low body mass index was reduced by 20%, and many other really good results. The 3-year results are now being analyzed, and we'll publish a paper on that soon. And we see this equity effect. We see that disadvantaged children benefit more, proportionally more than children from more well-off families. Girls generally benefit more than boys because they're usually more disadvantaged from the outset than the boys. We have developed a framework where we summarize the principles of the Fit for School approach into 3S. Everything that is done has to be simple, has to be scalable, and has to be sustainable. And those 3S need to be part of the program planning right from the beginning. If you start planning for a program and it requires a lot of resources, or it requires specialized workforce to apply a sealant or a varnish, that is not simple enough. And it's not sustainable because it needs extra funding. And it's not scalable because you cannot scale up the workforce to that extent so that you can reach a good coverage. So the more simplicity your program has, the better are the chances that it can be scaled and it can be sustained over a long time. One of the leading World Bank experts, Donald Bundy, said, it is not the question that school health and preschool programs are necessary. It's a matter of how can we implement them at a meaningful scale, because only with scale we can reach the numbers that are required. We heard the good examples from the field, but the numbers are low, are small. You make an impact in your surrounding community, but it is important that you think about what are the lessons learned from those small-scale programs and what can be taken to the bigger picture. To a district level, to a province level, to maybe even a national level, and how to make that change happen. What are your key learnings? So just to finish up my presentation, I know my time is almost over, a few key principles, and those are really rather generic principles. What makes a public health program successful? And that applies to whether it's a program for obesity, for oral health, for any other intervention. Those are really public health principles. The program needs to be relevant and needs to focus on what are key priorities. It is nice to have a program on sexual education, but if sexual education or sexually transmitted diseases are not the key problem of my target group, why bother? If my resources are so scarce, if I have only $1 to spend, what is my first priority choice? Where can I make the biggest impact, as I've said before? And I also need to look at what is possible in my surroundings. What are the resources that we have? What is the workforce available? What is realistic in the setting that I work in? The evidence is highly important. If you have little resources, you don't want to waste your resources on something that is not working, that is not effective. Of course, you want to focus on things that have good evidence, that are best buys in public health. A little investment, a big gain. So do not waste your time too much on too much health education, because it doesn't bring the benefit in the long term and in the big scale, in the bigger picture that you would like to see. Focus on something that changes the system. Think in systems. Your little intervention that you want to do needs to be part of a running government planning, budgeting, implementation process. If that is the case, you have better chances for sustainability. Involve the local communities. We have heard wonderfully from the examples from the field how important it is to build on the local knowledge and to use that. It is not possible to sit at the desktop here in Berkeley and to come up with a 100% matching program for a Maasai community in rural Kenya. It's impossible, because even if you are the best knowledgeable person and expert about Maasai culture, once you are there, you will see something else that completely distorts your picture and changes your program planning. So you have to involve the people and the communities, because they will know best what is their key problem. As Karen said, or as one of the comments said, for parents, usually the problem is my child is in pain. My child doesn't sleep at night. How can we address this problem? And if the community decides this is the problem that we need to work on, there will be more ownership for the program. There will be more support, and it will be more sustainable in the long run. As I've shown in the first picture about the determinants, intersectoral collaboration is important. You have to involve people who are outside of health, and you have to think of what are those key factors outside of my health arena that influence my health outcome or the condition that I want to address. And when you do this, of course, it is very important that roles and responsibilities between those sectors are very clear and laid down in agreements. The setting is important. If my environment is healthy and promoting health and conducive to health, it is easier to stay healthy. So if my school is a healthy place, has a clean environment, there are no animals running around, there's no shitting behind the bush, of course my kids will be more healthy and the pupils will be more healthy. It's something very easy. It doesn't require a high-tech intervention, and it just needs some clear thinking. And the same applies to so many other environments, starting from the household, ending in the workplace, with the workplace. Monitoring, evaluation, and research, as I said already, those are key ingredients. If I do something just for the sake of doing, I can as well leave it. I need to know that it works, and if it works, why does it work? How can I make it work better? And how can I transfer this knowledge to another setting? Will it work there? And now I've just taken this little graph from a standard textbook. What we do usually is in research, in academic research, we do basic and applied research. We know that something is effective. We know that something works in a lab-controlled environment. At most, we go out and do some community demonstration projects. We know some piloting here and there in a defined setting, a rural area, an urban area, whatever, a community that we control. But what happens if our intervention goes out in the wild and we go to large scale? We know very little about this. And we need more research that is called implementation research that follows what is happening in real life and how can we make it more sustainable and more effective. What are the factors contributing to a successful program that covers millions and not just hundreds or dozens? For this, it is very often very helpful to have technical assistance. Can come from an agency like WHO, can come from donor agencies, can come from international NGOs, can come from academia, from universities. If you are a local stakeholder, it is important to ask to look out for this kind of assistance. And it's a joint learning process, as someone outlined at the beginning of this morning. It's a give and take. As academic people, we learn a lot when we go out into the field, and vice versa. It's not a one-way process. And there's even the growing recognition that South-South collaboration is equally important. So if you from Bolivia, from El Salvador, and you from Tanzania, from Kenya, you discover, whoa, we have something in common. What can we learn from each other? That is equally important and necessary and should be promoted. It is important that whatever we do, we are able to show that it contributes to a bigger development agenda. If we stay in our small oral health or nutrition or whatever our niche is, we can do good things. But we can get more allies and more support if we can show that it contributes to the big things that a government decision maker is keen to show progress on. So if my country is doing well on the Millennium Development Goals, on the health-related, on the education-related ones, and I have a bunch of things that contribute to achieving this goal, of course I'm more than happy then to support it and to embrace it and to be part of that process. So we have to be aware of what is going on in the bigger picture to be sure that we have the best support possible. We need to plan for scale, and for that, as I said, it needs to be simple, scalable, and sustainable. We want to reach big picture numbers, and we want to address the problem on a large scale. For that, we need specific knowledge and a specific mindset that goes beyond the traditional pilot planning thinking. And we need political leadership. Saskia mentioned it, and some other people mentioned it this morning, that there are some government leaders, there are some celebrities who can be leaders, but we need this leadership on a daily basis in our district, in our province, on a national level, in our immediate environment. We need the people who promote the program, who are behind the program, who back it up. But they usually do not do it for the gain that we are in the program. We are maybe in the program because we want to improve obesity or undernutrition or oral health. A politician supports it because he wants to get re-elected. So people work because they have different incentives, and we need to realize this and build in the right incentives for the target group that we want to be allied with. And that's one of my last slides. I'm close to finishing. You all remember this from the Surgeon General's report. No one should suffer from oral diseases or conditions that can be effectively treated or prevented. And that was geared to the US conditions and the US context. But it equally applies to the world. And I think it's still relevant 10 years later. You have a first lady in this country who has herself taken on board a health issue with her Let's Move campaign. Here you see her in Mexico on a state visit while her husband is doing political negotiations. She goes into a school and promotes school health and physical activity in school. This is the type of leadership that we as public health people need, that we have to build on. But those people do not come to us. We have to go to them and offer them opportunities where they can engage and where they can make a meaningful contribution to a bigger good. The former Director General of the WHO, he said that health work teaches us with great rigor that action without knowledge is wasted effort, just as knowledge without action is a wasted resource. And I think this concludes very nicely what we have heard today. We need to act on what we know, but we should act with best possible evidence, with best possible knowledge. We don't need to wait in many areas for the perfect knowledge. We know already a lot, which justifies enough and bold action. But we need to make sure that this action is actually happening. So we need to leave our desks at our universities and go out into the field, engage with people on the ground. The people on the ground need to engage with the people who know about this scientific evidence to make things happening. So this is my last slide and rounds off what we have heard today. Any questions? Welcome. Thank you.
Why don't we take a few questions from the audience? Here.
Hi, Susan Ivey, School of Public Health here at UC Berkeley. So I'm very interested in your presentation and the Fit for Schools program and the focus on sustainability and scalability. But it did seem like you glossed over one point a little bit, which is bringing water to sites. So many of the countries where I've worked, there isn't water on site. And in one case, working with Global Medical Brigade, we actually brought students along to do Global Water Brigade so they could build cisterns and provide actual infrastructure for clean water. In your analysis of your costs and stuff, should we assume that didn't include the cost of bringing water to the sites? And are you talking about building cisterns and, hard infrastructure, if you will, so that schools and other facilities would have clean water?
Yeah, thank you for this. I respond immediately. You're right, this question is important. Looking at the cost estimations, these are running costs, 50 cents per year per child. There's a capital investment at the beginning of about $4 to $5 per child, which includes the water. So if there's no water access, it's either that a piped water access is built, or a well is there, or a cistern system is built. But the good thing is, or the important thing is, that when you want a school to engage in this program, that the school knows what are the running costs, what costs will I incur over the next 3 years, how long, what is the life of my facility, how long will it last, what is the maintenance that I need to do. So we did a lot of calculations, how much water is used at average for hand washing and for toothbrushing. And with that, you can come to cost calculations and estimations that give the school an idea about the affordability of such an intervention. And when you look at, you should certainly aware of the Unicef's water, sanitation, hygiene program, and particularly the Wash in Schools program. They have extensive manuals and planning guides on this. UNICEF has in the past focused a lot on building maximum facilities with tap water, with water closets, with digging 60-meter deep wells at high expense and high investments, neglecting the maintenance. And so there's a nice facility, but after a year it's no longer functional because the school cannot maintain it. UNICEF is slowly shifting. We had an agreement with them, and we have worked with them over the last 3 years to come up with a more sustainable program, low-cost investment, gradual improvements, depending on what is affordable and possible for the resources. You don't need piped water to do a hand-washing program.
But you might need a cistern.
Yes, but those are simple things which are available in the community. You go to the village shop, you find a cistern like that, which costs you $15, $20. And every morning, someone is scheduled to bring in the water, which will run for the entire day.
Another question or comment?
Yes. Thank you. My name is Bahar. I'm a faculty at UCSF, a dental public health person. I really like the illness factory concept. And my question comes to policies, global health policies, especially when it comes to the global nutrition transition that's going on. How do you think the work of let's say the example of CAFTA, the trade agreement with the United States and Central American countries, which basically those countries cannot control what's going on in their trades. They cannot control the food advertisement in their countries. How do you see WHO or PEHA or other health organizations contribute to these global health policies?
Yeah, very interesting, very relevant question. Thank you. And I think it's more for Saskia as a representative of PAHO to respond. But generally speaking, when you look at the Global Action Plan for Prevention and Control of Non-Communicable Diseases, many of the policy options and suggestions to countries which give guidance to countries on how to address the problem which relate to these risk factors, many of those policies, templates, they relate to national legislation, to increasing taxes, to making healthy choices easier, to making unhealthy choices more difficult, to limiting importation, to banning sales in certain settings, etc., etc., etc. So those are things that do not cost the government a single cent or very little. If you establish a policy on a tax on tobacco, it doesn't cost anything to pass the law, but it has a big public health impact. And you can use the revenue generated from that tax on tobacco to spend it on some health promotion activities, which many countries do. Thailand has a health promotion foundation building largely on tobacco taxing and alcohol taxing, has $110 million to spend every year just on health promotion. So these are systems that work. Of course, free trade and liberal trade are withstanding these restrictions. And some may say those policies are promoting a nanny state, which intervenes in my individual choice that I have as a person to buy certain things or not to buy certain things. It's an ethical, fundamental public health debate that we can spend 2 workshop days on elaborating. I'm a huge proponent of government policies in this way. Maybe Sasi would like to add something.
I think one example that I can give you is in Mexico, where Mexico has already made significant progress in terms of, controlling better comida chatarra, junk food, and just restriction, which also affects, the global market. I think and how does PAHO fit in? Well, PAHO kind of comes with some of the guidelines, and it's not like one part of government of one organization is leading that, but this is where the dialogue, it's much broader, it's more complex than that. I think, for example, with the guidelines for reduction of sugar, we know already that sugar industry is already lobbying Congress, They're already screaming and yelling, why you let WHO, and this is where, you got to negotiate that, and some countries may say no, and some countries will make those significant changes, but it's complex, that I can tell you, but it's important to sit at the table and to be part of that, process. And I think this is where PAHO, the World Health Organization, and the UN will. There is a call from the UN. It's the UN that come up with this mandate, and it's because governments, presidents said, hey, these NCDs are eating our budget. We need to do something about it. So if you start moving forward to implement that call, and then the government back off, then there is a contradiction right there. Another good example would be what we do with salt. There is a mandate to reduce salt in processed food, and obviously that's going to have implications with the industry. So you just have to work with it. Okay?
And it seems like a very difficult and challenging thing, and it certainly is. But it's not impossible. I mean, think back 20 years. We were smoking on planes, and we were smoking in restaurants, and it was just normal. And now it's like, if you do this, you're a social outcast and you're arrested. So things can change, really. And the food and beverage industry may cry and say, if we ban smoking in restaurants, nobody will come to our restaurant anymore. What happened? The opposite happened. More people go to restaurants because they are smoke-free.
So on that positive note, why don't we thank our speakers from the morning session.